it may fall on deaf ears if he's not willing to quit or if he's not ready to quit. So I would say starting with his willingness to quit is important. However, I'm not against kind of powering through and maybe letting him know quitting is going to be what's best for him, and these are the reasons and the things that we can do to help him get there. I also like the thought process that I heard in terms of, getting that PA if it's required. Maybe something for you to work directly with the community pharmacy with, but also very, very helpful to make sure you're thinking through that with the patient, depending on his insurance, thinking through that access to care here. Just about everything that you guys named is noted here on this slide. The only thing that I have here in addition is because Entresto does have a dose increase, you want to get to the maximum dose, the maximum benefit dose here. It is something that you can let the patient know you should expect that you're going to be taking a different dose than this in about 2 to 4 weeks. That could be education that you could deliver. Some clinicians could choose to not say that at this time and wait for the patient to follow up and have that discussion then. It's very clinician specific. I would also implore the patient to really make that follow-up appointment because there have been a lot of changes that were made that I do believe are beneficial. And whomever their primary care provider is going to want to talk to them not only about their hospital stay and their adherence, but about the changes that were made and how they proceed going forward. So you can never tell a patient enough times that they should really keep their follow-up appointment for after their hospital discharge. And lastly, one thing that I didn't hear was kind of just giving them some information also about their non-pharmacologic treatment that he can do for his heart failure. And so that's going to include his daily weight checks, making sure he's weighing himself so that if he is gained and or lost over that 2-pound limit, that he can call in and talk to someone about it. Fluid and sodium intake, of course, are going to be things that we want to discuss with him and give him education about in terms of limiting both so that he can prevent the extra fluid in his body, as well as any additional signs and symptoms of exacerbation. So he's pretty familiar with what an exacerbation feels like. That's what he came to us with. But if we can give him some more preliminary signs so that he doesn't get to the point where he ended up in the ED, maybe he could see his primary care physician instead, and possibly a little extra PO Lasix can help him out rather than being admitted to help get him out of his acute decompensation. So our groups 23, 10, and 18 gave us a lot to talk about and really covered most everything that I wanted to discuss. Are there any other groups in the class that had anything else that they wanted to ask about or discuss with the patient at this point?
This is group 19. We actually said that he was eligible to receive the PTSD 23 vaccination for the CDC guidelines because he has a chronic heart condition.
That is a very awesome point. I appreciate you bringing that up. So not where I was thinking when I built this case, but definitely vaccinations is something that we should be looking at as well. It's a medication. And so if he hasn't already been vaccinated, take a look at his status. And I know a nurse in any hospital would be happy to administer that vaccination to help keep the hospital within meeting their quality metrics as well. So very good catch there, group 19. Any other groups have something they want to share? It's unlikely that already having this disease state, you would find that this patient didn't have what he needed to monitor his disease. But if for any reason, say he didn't have a blood pressure cuff already, and say, for instance, oh, we just happen to have one lying around in the hospital, that's perfectly brand new to give this patient. This is the time at discharge where that kind of counseling could happen as well. So if he had the cuff, or maybe the caregiver brought it in from home because they said they didn't know how to use it or that it wasn't working, this would be a point where you could take some time to teach them, use the skills that you've learned to inform them, hey, this is how you check your blood pressure at home. You can just record it, make sure you bring it to your doctor when you see them. And this is the time at discharge to do any of those types of training. So last week we had our patient who was a newly diagnosed diabetic. If that patient happened to be able to have that glucometer present, that kind of training could be given as well at discharge. So thinking through, making sure if there are any new devices involved or any type of non-pharmacologic monitoring that needs to occur, it's at this point where you could really let them know this is how you use those. And utilizing your teach-back method that you've learned can help you make sure that you have given the patient the information in the way that they best understand. The only other thing to state here is that discharge, sometimes we discharge patients on high-risk medications. There's nothing on this patient's profile that would be considered high risk. Some of the different types of high-risk medications that I'm considering are things like an anticoagulant, like warfarin, insulin, would be considered a high-risk medication, so we discharged someone on that last week. It's anything that could, if not used appropriately, if the counseling and the recommendations aren't followed appropriately, can cause some pretty life-threatening issues. So taking warfarin inappropriately can cause a bleed. Not taking it at all if you really need it can cause a clot. Hypoglycemic risk with insulin. And so if at this point you have a patient who's being discharged, you want to keep an eye out for those high-risk medications and make sure that you give them a little bit of extra love when it comes to those meds, a little bit of extra information so that you are ensuring that they're using them appropriately. Because we would love to say that everyone in the community pharmacy outpatient world is giving that information to our patients. But I know that when I go to the pharmacy, sometimes it's not as often given as I would like. I usually ask to be counseled when I go to the pharmacy, and I get really great information. But if you're not asking for it, it's not typically happening. And a lot of patients don't typically ask for it. So if they're gonna get the counseling, you wanna make sure that if you're in the hospital, you can receive that counseling at that point, because you can't be certain what's gonna happen at the community pharmacy level. And here we are now. KH is headed to community pharmacy. He has his discharge medications with him. He has a current profile at that pharmacy because he has been getting some medications, but he also has these prescriptions that he just left at the hospital. He's going to have these filled. So my question to you all, at this point of the transition, when we're thinking of not only going from the hospital to community pharmacy, but also community pharmacy to home, what kinds of things, what kind of impacts can we have here when it comes to this patient?
No, it's not. Just the print. What made this one more expensive? I don't know. Because it's 31 stars. Select. Select it and go to it. Go to buy. Build your own. Back. Back. Select.
Okay.
Next step. What's this? Do you want that?
No.
Next. Do you want that?
No.
Next. Why is she giving us so much time for these little?
Yeah, they sell those little things.
Camrys are actually decent.
I tried to stop my iPad.
That's the new Camry.
Oh, yeah.
Alright. I'm down.
If you got a Yaris, I would judge you so hard.
I would judge myself.
Prius. Camry 2019. Camry Hybrid. Do that. Avalon. You don't like Avalon. Because it's like the luxury class of Toyota.
That's what I wanted it for. Super white.
Super blue. No.
The difference in that and that is the
At the top. Ooh, I like that one. Yeah. No, that one.
Yeah, I saw that.
What?
Like, what the heck?
just rude.
Then take it off.
That looks very white.
It's too white. Do that one.
No.
Do that one.
I like the white.
That's too white.
No. It's super white.
Starts at 34.
Hondas don't make V6s anymore. Mine's a V6 and I really kind of need
I
that.
feel like the newer, four-cylinder ones are comparable to the older V6. So it's fine. You're fine.
She's gonna have one more after this. She's literally just wasting time. This can all be done in one singular hour.
It's a VK.
What?
I don't know what it is. Okay,
I don't know what it is, but I want it. I want the smallest number of airbags so that if I crashed and it was going to be fatal, I would die and not be in a coma.
Okay, dear.
I don't want to deal with the coma issue.
What I want to know is heated seats or
Go. You're going too slow.
because I'm trying to actually read it.
No, I want to look at it too. Look, this is not about you. Okay, that's it. This is the one.
No,
You were looking at that L.
no, I was not. I was comparing them.
Oh.
That's acceptable.
Now, let's pick a proper,
White.
no,
Yeah.
gray.
Oh my god.
White just gets dirty so easy.
Yeah, I have white now. I know.
Wait,
Yeah.
white's better than black.
Yeah, but gray is a nice halfway, and it doesn't get dirty so easy.
Gray just looks so.
I mean, it's better than
Gray's a good color.
ugly
It's good.
red.
It's a good neutral.
That red is disgusting. That brown is disgusting.
This green is not cute. Do gray.
I keep dropping everything all
My
over.
goodness,
I'm
Kendall.
so sorry. Thank you.
$400 for mats. We don't need mats.
No, Aaron, we do not need mats. Like 29,000.
Local specials. Oh, I wonder if we can find this on Groupon for like $300. I'm gonna do that one day. I'm gonna roll up in a Lamborghini. Guys, I found this on Groupon for $500.
Let's look at one I would actually be okay with.
The ugly ass white
Hearing
ones.
my models.
You need a G-Wagon.
All right, coming back together, you guys. Group number 1. Can you go ahead and give me 1 to 2 things you identified as being necessary for transitions at this point?
We said in order to check on his adherence, use a pillbox or an alarm on his phone, and maybe set him up for auto refill.
Awesome. Group 9. What other things or additional things did you identify?
Any cost considerations?
I'd be happy to hear from any of the other groups that may have already been called on that have some other things that they want to share.
Make sure the pharmacy knows that the patient is supposed to stop the lisinopril and switch the metoprolol, and then counsel the patient, make sure they know what they're taking as well.
Anything else?
Since he was previously not adherent because he ran out of refills, we could sign him up for MedSync or blister packing.
Blister packing sounds painful.
You guys are definitely thinking outside of the box. Very nice job here. So a lot of the points that were not mentioned, and I'm sure because you guys didn't want to be redundant, are a lot of the same things that a discharge pharmacist in an inpatient setting can have as a community pharmacist at the community pharmacy setting. So a lot of the same education that's provided, it's okay to provide it more than once. And typically patients need it more than once. So the same counseling about non-pharmacologic recommendations a patient will likely benefit from and need. The same counseling that you guys talked about, nicotine cessation, could be beneficial here, especially if this is his community pharmacy. These are people that he's closer to, that he sees pretty frequently. Maybe they'll have an impact there as well. I heard from the groups in terms of making sure that he's completely aware of his medication changes, as well as making sure as a community pharmacy you're aware of those changes. So in your system, making sure you know that to stop the lisinopril as well as stop the tartrate, so that you're not refilling those for that patient, and knowing that they have been replaced by the succinate as well as the Entresto is going to be important. And whether documenting that to meet our middle or our inner circle of our patient care process, possibly in the medication notes section. It depends on the type of pharmacy system you're using, but making note to yourself of, okay, this is why we're discontinuing this medication so that it's clear to all parties involved. In case the patient calls or comes back and says, this is different from the med that I used to be on, what's going on? everyone has, and that can be communicated through that documentation. Everybody's aware. But providing that patient education is going to be important there. I heard things about adherence in pill boxes, so that's definitely an important thing here. And in the community pharmacy setting, depending on your pharmacy, it's likely that you have those types of products available that you can maybe even help him set up before he leaves your pharmacy today. And so maybe he finds something like that beneficial. Setting up the alarm on the phone, definitely something you could help him with. I mean, he's pretty young and spry still, 42, so he may be able to work his smartphone on his own. But if you had someone like an 80-year-old who's having troubles with adherence, maybe they need a little help with their smartphone that their grandkids got for them. So being able to help there in terms of that transition of care would be important. I like the sound of the auto refills or the MedSync. MedSync is a big thing that's been gaining a lot of traction over the last couple of years, and a lot of studies have shown that it's beneficial for patients to be able to pick up all their meds at one time, and it increases adherence. So that could be something that he could benefit from if this is available at that community pharmacy. Blister packing is definitely something that has been done a lot in nursing homes, but is coming to the mainstream more so now. I think I told you guys about last week, but I saw advertised from Amazon. So that's a version of a blister pack, sort of. But it's also done by other companies, and it's done by pharmacies around and across the nation. And so maybe this is a pharmacy that can offer that option to him to help increase his adherence as well. I heard cost considerations, and that's a big one. And so not only can you have benefits working in the hospital setting of being able to help with PAs and prior authorizations, as well as maybe even patient assistant programs, that's a big role that I'm sure for any of you who work in community pharmacy currently or have gone through your IPPEs, you know that we can play a big role there as pharmacists in terms of making sure that our patients can get these medications at affordable costs. Just the other day, I had a pharmacy intern help me get some stuff for my mom at a discounted price because she's here visiting me from Connecticut. So it's definitely a role that not only as interns, as pharmacists, you can play for all the patients across the nation, no matter where you practice, okay? Health literacy is going to be important here. I think I talked a little bit about this last week, but making sure you're breaking things down to layman's terms for the patient so that they're understanding what's going on. And we talked a little bit about vaccinations in the hospital setting, but as you guys know, community pharmacists, again, across the nation, and especially here in Georgia, can and have the ability to give vaccinations. And so this is at a point where you could try to identify, if he meets these criteria, has he already received his Pneumovax? If he has, then that's not a role for us to play here in the community pharmacy, but if he hasn't, say he denied it in the hospital, this could be your chance to kind of coax him into it and explain to him why it's important. So vaccinations can be a thing and a point of transitions of care here at the community pharmacy level as well. The one thing that I didn't hear from any of the groups, and I don't know how much exposure you guys have gotten to these types of more clinical advanced practices, but it's these concepts of comprehensive medication review and chronic care management. So over the last couple of years, chronic care management also has taken off, and there's a lot of different insurance companies that do this process for specific patients. But when I talk about chronic care management, I mean for any patient who is expected to have a disease, a chronic disease, for longer than 12 months, providers can get paid for making sure that we're keeping patients abreast of their issue and following up with them on a monthly basis for at least 20 minutes at a time. And so there are some community pharmacies out there, whether they're independent or big chains like a CVS or a Walgreens, that are performing these services for their patients who have chronic disease states like heart failure, asthma, diabetes. So our patient would be a perfect candidate if we had that type of program at our community pharmacy to enroll in chronic care management so that we could help keep them adherent and keep on top of his heart failure and make sure that he is doing his daily weight checks, so on and so forth. Because really, a big part of patients becoming non-adherent is not being held accountable. And so if you're talking to someone every month about your disease state, you can be held a little bit more accountable for keeping up with it versus if you're only following up with your primary care physician every 3 months. So chronic care management aims to help keep patients accountable. And not every community pharmacy has this within them, but there are a lot of them that are starting to do it. And you guys are going to learn about provider status a little later in the semester, and that's a big part of it. If we get provider status, we can start as pharmacists billing for these chronic care management visits and making a little bit more revenue in our pharmacies, okay? So those are some of the things that we could take a look at. Any questions about anything that I talked about at this community pharmacy level, or any groups with anything that they had that they want to mention now that they didn't mention earlier? Hearing none, we're going to move on to our last portion of our patient case today. This is going to be what's called a shared medical appointment. I don't know if you guys have ever heard of this, but this is, some practices are using pharmacists in the setting to meet with patients with the physician. And so that's why it's termed a shared medical appointment. We go in with the physicians that are also following up with the patients. We focus on the medications and the adherence and those types of feedback to give the patient, and the physician focuses on what they are trained to focus on as well. But it's really honing in on, if you guys have heard that term, which I'm sure you have, that interprofessional team care and that interprofessional working together as a whole unit. Not only happens in the hospital, but can happen in the outpatient setting as well. So he comes to his outpatient follow-up 7 days after his appointment, being discharged, 7 days after his discharge from the hospital for his acute heart failure episode. He has no complaints today. He states he's feeling a lot better, so that's good to hear. You guys have the information presented for you there in terms of his vitals at this visit. And you also have his home medications that he reports that he is taking currently, despite all of the education we've provided to him thus far. So I wanted you guys to take some time in your group. This is our last kind of case portion of the day. Take these next 10 minutes and really figure out how we're going to get this guy to get the picture that we've been trying to give him at his last 3 transitions of care interactions.
know if they still
I'm
got
worried about it. They don't remember
There's a way you can unsubscribe from her email.
No, I tried at the beginning of pharmacy school, and it took me off of every listserv, and I had to talk to the administration to get me added back to the important listserv, and they added me back to all of them.
I think that there's a way to get unsubscribed from her. I think some of the fourth years figured it out.
Get me in contact with them. Stat.
Can't you just like send her to your spam folder?
I don't know how to do that.
Mark it as spam.
If you mark like a sender as spam, I don't think it'll come to your.
Can you mark her as spam?
Yeah.
Or like just her email?
No, you can mark like a sender as spam.
Looks like my shade of blush that I'm about to run out of.
Still smells citrusy. Also, how long have you even washed your hands? She just doesn't like on my skin. But how do I know you washed your hands? How do I know that's
Water.
Why is there so much funny stuff on Facebook today? It's not.
Because you're tired and everything's funnier. I get like that some days, and I'll just start sending my friends like 10,000 things.
Is this a meme?
Asma's just like loopy. She's delirious right now.
I was gonna say, it's okay if not.
Have you seen the Marie Kondo show?
Mm-hmm. Spark Joy.
We have a meme for that.
Ooh, let's see it.
It's that one.
I was just about to say.
What, the show or the meme?
Her.
Oh, Marie Kondo. Yeah. I don't get why the show's this big of a hit. It's
I
literally just someone clean.
Her tip is the same for everything
Yeah.
that you know.
Yes, I just got a hit.
That's like some shit that would happen in Game of Thrones.
What? She takes. I used to like Dr. Sigh.
I'm sorry, I'm like all over your bubble.
You're fine. I'm not. I'm just ready to go.
He's not that rich.
He's the one that lives over the bridge.
Did you say Gossip Girl?
Dan. From it's Dan. Dan
I have a pin.
Huh?
I said I have a pin for my lab coat. It's XOXO. Alicia got it for
I'm
me.
rewatching Gossip Girl right now.
Oh, you're rewatching it?
What part are you on?
Blair was married to Prince.
I watched that last year during finals, and it changed my life.
Oh, Gossip Girl?
Yes.
I can't even tell you what number this is that I'm like rewatching it for.
I rewatched This Is Us over Christmas break because I didn't see the third season, and now they just started the fourth season, so now I'm gonna have to rewatch.
It's coming back together for our last transition. Group number 24. Can you please give me one or two things you identified that can happen at the Share Medical Department?
Group what? 24.
Sorry, we were trying to find the remote to turn our mic back on. Group 24 talked about doing the smoking cessation, or talking about with the patient about that again, and then also reinforcing them to not be taking lisinopril and Entresto at the same time, and then again discussing medication adherence.
Very good. Group 3, who are my last remaining group of these last 2 weeks. Anything different or anything you'd like to
She
add?
did. Very last question. This was us last week.
We discussed obtaining a BNP because he's taking the lisinopril and the Entresto together, so his potassium might be a little out of whack, so we thought we might want to check on that for the patient.
Okay. Any of the other groups identify anything that could be discussed in this visit? And it doesn't have to be something that's completely different that we identified in a different transition. So anything you'd like to add, any of the groups?
No, can we go home?
So can I say also check with him to see if he's doing the daily weight checks.
Very good. So checking on that, the non-farms that were provided as education, important as well. So nice job, you guys, to come together to bring all that information to one place. So one of the things that I'm sure you're sitting there telling yourself is, we already talked about this, this is really redundant. But that's the point of transitions of care, is to catch the things that may have slipped through the cracks at other points of the transitions. So if I'm talking about giving a vaccination at discharge at the hospital, and for some reason that gets missed, then yeah, I'm gonna want you guys to be able to think through the fact that that vaccination can be given at the community pharmacy level. And if for some reason it's missed there, maybe it's a crazy hectic day at the community pharmacy, then that same vaccination should be caught at the shared medical appointment as a necessary thing for this patient. And so transitions of care has redundancy because that's the point. We want to make sure that these things are not slipping through the cracks and that this patient's health care is well intact. So if you're sitting there thinking to yourself, we literally just said this to you 2 minutes ago, it's because regardless of the fact that you said it in the last setting, is to implore to you that no matter what setting you're in, pharmacists can have these impacts very similar impacts, whether it's an emergency department pharmacist, an inpatient internal medicine pharmacist, or your local community pharmacist or independent community pharmacist who's working to try to make sure that this patient has the best health care. So I agree with the things that were stated by the group. Smoking cessation is definitely a conversation that can happen here. If you see per report, patient didn't continue the nicotine despite whatever education that we've given or provided. And so it's possible that providing that smoking cessation education may work here at this visit, even though it hasn't worked at previous junctions. Reiterating that heart failure education, so